Mr. Chairman, ladies and gentlemen, first I want to thank the organizers from the Portuguese Society of Cardiology for inviting me to talk about the German experience regarding the Takotsubo cardiomyopathy registry in Germany. I must state I'm not a professor, I'm only a simple doctor. Background for this registry was that the Arbeitsgemeinschaft Leitende Kardiologische Krankenhausärzte, AFKK, initiated this registry to further evaluate the syndrome in a Western population, especially in German patients. This Arbeitsgemeinschaft is a working group of cardiology department directors in non-university hospitals. This working group is a member of the German Society of Cardiology, and this registry has no funding. At the beginning of this registry, we were very ambitious and we wanted to address many issues, many questions. We wanted to evaluate different patterns of the left ventricle involvement. We wanted to evaluate clinical management and therapeutic strategies. We wanted to evaluate clinical course and possible complications during the hospitalization. We wanted to evaluate gender differences, circadian and seasonal variations in the occurrence of the Takotsubo cardiomyopathy. We wanted to evaluate influence of coronary abnormalities, e.g. myocardial bridging, and further on. 37 centers participate at the moment in this registry. 36 centers were located in Germany. You can see we have centers in North Germany, in the middle of Germany, in the south of Germany, and we have one center in Austria, in Vienna. Initially, we had a web-based data entry system, but soon we changed to a paper form because it was too expensive, and the centers didn't like it. We decided to establish this form. These are 6 sheets with information about the preclinical status, preclinical management, ECG at baseline, laboratory findings, complications during hospitalization. Here, echo data, invasive data, cardiac MRI data. Cardiac MRI was not mandatory, and I must say that only 4 centers performed cardiac MRI in these patients. One of the centers was my center, and we have now more than 150 patients. We performed in about 120 patients an MRI. On the last pages, we have an ECG at day 2 and day 3, and we performed a short-term follow-up about 3 months. We asked all the centers to send us hard copies of letters, admission letters, discharge letters. We asked all centers to send us copies of the ECGs, to analyze these ECGs, and we asked all centers to send us copies of the echoes, the MRIs, and the catheter investigation. The registry began in the year 2006, and enrollment of the first phase was ended in the year 2009. In this period, 410 cases with suspicion of a Takotsubo cardiomyopathy were submitted. You can see here the centers, 1 to 37. We have 3 centers with a lot of submitted cases. I call them high-volume centers. Number 20 is my center. And we have a lot of centers sending only 1 or 2 cases. These are 5 cases. And this is a problem of our registry. Inclusion criteria. All submitted cases were reviewed by 4 cardiologists, 2 in my hospital and 2 from my co-worker, Ms. Schneider, in Lübeck. A patient was included in the registry when this criteria was met: acute chest symptoms or syncope or other symptoms associated with reversible ECG changes with the C-segment elevation and or T-wave inversion, reversible left ventricular dysfunction with a wall motion abnormality not corresponding to a single coronary artery, and no significant coronary stenosis. These are the same inclusion criteria as presented by my speaker before. Patients were excluded if there were present a pheochromocytoma, a myocarditis, a tachycardia-induced cardiomyopathy, or a subarachnoid hemorrhage. Here can you see the cases which were included in the registry. From the 410 cases, we could include only 324 patients. These are 79%. The low volume, from low volume centers, we could include or not include any patient. From the high volume centers, we could include the most patients. Exclusion criteria or reasons for exclusion in these patients were incomplete data in 13%, significant coronary disease in 5%, a myocarditis proven by endomyocardial biopsy in 2%, 8 patients, supraventricular tachycardia in 0.2%, and other reasons 1%. Now I want to show you some data from our registry. These are the baseline characteristics from the 324 patients. 91% were female, 9% were male. The mean age was 68 plus minus 12 years. Age ranged between 90 and 99 years. Only 77% had a triggering event. Emotional and physical was equally distributed. In 23%, we couldn't have found any triggering event. The majority of the patients had angina, but we also found dyspnea, syncope, shock with resuscitation in 6 patients, other symptoms, gastrointestinal symptoms, and 8 patients had no symptoms. We looked at the different TTC involvement, and we identified only 2 forms, the apical ballooning form and the midventricular ballooning form. We found no reversive or basal Takotsubo or focal Takotsubo cardiomyopathy. The distribution was 64% with apical ballooning and 36% with midventricular ballooning. In an aerial analysis of these both groups, apical and midventricular, we found no differences regarding age, gender, symptoms, or triggering events. Was distributed equal. Also, the different triggering event forms, physical or emotional and physical or emotional, was in both groups similar. This is a very busy slide showing ECG changes between the both groups, apical and midventricular. Yeah, at day 1, day 2, and day 3, we could observe that ST segment elevation decreased during day 1 to day 3 in both groups. Negative D waves increased and reached a maximum after day 3. Q waves initially more present, decreased after 2 days. No significant differences between the both groups. Another issue, clinical management. In this registry, the most patients were sent to the hospital by emergency physician. 24% by general practitioner, 11% went directly to the emergency department, and 6%, 20 patients, developed a Takotsubo cardiomyopathy during hospitalization. Time from symptom onset to hospital arrival in our registry was 7.6 plus minus 6.9 hours. It's a bit longer than in patients with acute myocardial infarction. The majority of the patients were treated in the intensive care unit, 29% were treated in a normal ward. Here you can see the initial diagnosis of these persons who admitted the patients to the hospital. The most patients were admitted with suspicions of a ST segment elevation infarction. 39% with the diagnosis of non-ST segment elevation infarction. 2 patients with pulmonary embolism, 3 with cerebral ischemia, 31 patients with other diagnosis, and 6 patients with no diagnosis. The initial medication varies very from center to center. Nearly all patients, 89%, received aspirin. 45% received clopidogrel. Only 42% received both aspirin and clopidogrel. 91% heparin, with patients with beta blockers, nitroglycerins, ACE inhibitors. 36% received diuretics. 10% received in the acute phase catecholamines. Other medications in 127 patients, and only 3% patients need an intra-aortic balloon pump. Everyone thinks that cardiomyopathy is a benign entity. It's not true. We find a lot of initial in-hospital complications. Pulmonary edema was present in 30% of the patients. Cardiopulmonary resuscitation in 4%. Cardiogenic shock in 7%. We found in 3% of the patients left ventricular thrombi, in 4% an interventricular gradient. Looking patients which we analyzed every day with echo, we found in 19% of these patients an RV involvement. In patients with MRI, 50% LV involvement. We had 1 myocardial rupture, 7 deaths, and 7 recurrences in a short-term follow-up. Regarding apical and midventricular forms, there are no differences. Regarding the in-hospital complications, the distribution is equal. Also the distribution, left ventricular thrombus, interventricular gradient, and in-hospital death. Here's an example of a patient, 67-year-old woman with a remarkable right ventricular involvement. The majority of the patients with the right ventricular involvement had pleural effusion and a two-sided pleural effusion. This is the follow-up 30 days after. You see complete disappearance of the right ventricular involvement. If you looked at the apical forms and midventricular forms, we found 37% of patients with RV involvement and 48% of patients with midventricular involvement. Another complication, this is a patient with a large interventricular thrombus. Here in the 2-chamber view, here in the 4-chamber view, after 3 months, complete disappearance of the thrombus. We looked also on patients with myocardial bridging. We found 19 patients presenting a myocardial bridging, and these were women. The most had angina, but all the other variables were similar with patients without myocardial bridging. Here is an example of a patient in the first row. Here you can see the myocardial bridging in the LAD, here the apical ballooning. Interestingly, patients with myocardial bridging had frequently more interventricular thrombi than patients without myocardial bridging. This is a patient I showed you before, with the apical ballooning and a large interventricular thrombus and a muscle bridge in the LAD. And a few slides to the circadian variation. In Germany, the most Takotsubo's occurred in summer, in July, with 13% frequency. Looking at the day of the week, we found the most Takotsubo's on Wednesday and Thursday. Interestingly, a lower frequency of Takotsubos in the night, equal distribution during morning, afternoon, and evening. Here is an analysis between men and women. This is German. We found that men predominantly had a Takotsubo in autumn and in July and November. It's not significant. Very interestingly is that the men in Germany developed the Takotsubo cardiomyopathy at Monday and Friday and Tuesday. perhaps working in Germany is, at the beginning of the work, very stressful. You heard a lot of limitations regarding the registries. I have only a few remarks. The initiation of this registry was very easy. We had low and high volume centers, and cooperation with the centers depends on the individual activities of the centers. The inclusion of TTC patients was and is often difficult because of missing data, and this registry don't provide data on pathophysiologic mechanisms. Thank you for your attention.